So I would be presenting few cases from our center. I've put it our experience because it's not the cases done by me alone, it's the team's work. So I must say that in our center, we started, unlike other people who has presented, Avinash has presented and all. So we started in the patients who are having atrial fibrillation, persistent atrial fibrillation, sick patients, arrhythmia-induced cardiomyopathy. So our initial cases are those cases in whom we have done AV junction ablation. So I would like to start this case with this case, 53-year-old lady, NYJ class 2-3, since last 6 to 8 months. She was having ECG of persistent atrial fibrillation since 2014. I've never seen sinus ECG in her because I was following her consistently. She's diabetic, hypertensive, normal coronaries, hypothyroidism, autoimmune disease, and with chronic glomerulosclerosis, initially on medical management, AF with FVR. So she was on dialysis in between with a dialysis sheet with the multiple admissions for CKD, and that was her biopsy for glomerulosclerosis. And she was on warfarin for atrial fibrillation. On warfarin, she was having some admissions. You can see her INR in between, it became 6 or something. She was receiving FFP and discharge. So what we did was, and she was having, we thought once we should admit her, do T, if there is a no clot, we'll try to do cardioversion, because she was having heart failure hospitalizations as well. But because there was an L appendage clot, she was in CKD 2-3. With all these things, her GFR was less than 30. So she was put on Eliquis 2.5 BID. So on this dose, this was her echo with the EF of around 43% with some pericardial effusion, some restrictive filling pattern, and with the IVC congested. So she came on Eliquis of 3.5 with the peripheral arterial thrombosis, for which Fogati was done. And by this time, because creatinine was little better, and with that dose of Eliquis, she was having thrombosis, we increased the dosage of Eliquis to 5 milligram BID. And then because we were not able to manage her medically, we thought we'll do his bundle pacing with AV junction ablation for her. This case was done in February 2019. So it's just a mapping. Everyone has seen this since morning. This is a his bundle mapping, and you get a good current of injury. And then there's some data saying that if your first potential, your first EGM is more than 40 milliseconds from the onset of the pacing, it's kind of a selective his pacing. We got a good, nice selective his pacing in this patient. You can see the threshold was also good. We were checking the threshold. AV junction ablation was done for her. And this is a very nice thing. This is on her follow-up. She came 10th day on the follow-up. This lady never had a sinus rhythm. And now you can see the ECG. In lead V1, you can see some P waves. So in all our cases, I would say that whenever we say persistent atrial fibrillation, we think that atrial lead we should not put. We just put ventricular lead because we accept that as a permanent atrial fibrillation, we do AV junction ablation. For our group of patients, we put atrial lead, and we could see that there is a sinus rhythm which is very slow. And then her rate was 30, and then you can see this is on follow-up. She is having A pace and B pace. This lady has completed now more than almost 1 year of follow-up. On the device, there is not even a single episode of atrial fibrillation. She's not having any heart failure hospitalizations. And you can see her echo has improved. There is no pericardial effusion. And now her creatinine is 1.9 and GFR 1.1, and GFR has improved to 53. This is a second case. This is a 66-year-old male, severe LV dysfunction, COPD, biatrial enlargement, chronic persistent atrial fibrillation, repeated heart failure hospitalization, and he was on optimal medical therapy with multiple attempts at cardioversion failed. This was his ECG. You can see it's a RBBB with much more fractionation up to V3 and V4. It's not only RBBB. We can say that it's much more diseased heart. So this patient was taken up for the physiological pacing. So with the selective his pacing, we got a good selective his pacing, but you can see that the right bundle branch block was not corrected. So this was, we did little distal pacing. It's a not selective his pacing. And with the fusion achieved from the RV lead also. So RV septal pacing, and you can see there are 2 stim there. So 40 millisecond distance. So only his bundle we were not able to achieve very narrow QRS. It was narrower. But with the fusion with the RV lead as well, we got a good narrow QRS. And this is the lead position. This patient also improved, and we did cardioversion for him on table itself. And you can see this is post AVJ cardioversion. It's a sinus rhythm. So this patient has completed, this was one of the initial case, was done in June 2017. But this case, after 1.5 years, his threshold increased. Its baseline threshold was 1 at 1 millisecond. Now his threshold is around 2.5 at 1 millisecond. So this patient now his battery is draining. Now this is the only patient which is showing battery life of only 1 year. It's a 2.5 years follow-up, and the battery life is just 1 year. So this patient we are thinking, because his EF has become completely normal now. He was EF of 30%. So we are thinking once he comes back, we can downgrade the device. This is a third case, 76-year-old male, persistent AFib, severe LV dysfunction, CKD this case, and the EF there was much more sicker patient, EF of just 20%. This is one of the emergency visit of the patient. This patient was thought to be it's a VT going on, and they gave shock, and after the shock they realized that it's an AFib with very fast ventricular rate. So this just, I'm trying to show this is the pacing, you achieve non-selective, you can see there is a pseudo delta, narrowing of the QRS.
Okay, go back.
This is the position of the lead. This is non-affording patient, so we have not given defib lead. This patient was given just a pace and lead. It's a CRT P connected. And this patient, you can see, this was done in January 2018, and it's October 2018 ECG. So it's cardioverted in sinus rhythm, but atria pacing, ventricle pacing, you can see. And this patient's his threshold is 0.7 at 0.8, and his 2 RV was kept at 50 millisecond. So we at our center started his bundle pacing. We are thankful to Dr. Vijayaraman because he started the program at our center in January 2017, and we have published our first 19 cases. So I must admit that all of our initial cases, like out of this 19, 15 were CRT cases. Out of that, 11 are AFib with fast ventricular rate, with sicker patient with the tachycardiomyopathy. And slowly now after this we are changing. Like initially we used to put backup RV lead, but now with the confidence we are not, many cases we are not putting. So there is only one case where the single chamber pacemaker was implanted. This is a 11-year guy with corrected TGA with congenital complete heart block with severe LV dysfunction. So this is the only where till 2019 June we were doing mostly CRT cases, few only dual chamber, and these dual chamber cases are those in whom we have not put atrial lead, we have put his and the RV lead with the AV junction ablations, but maximum we have put the RV lead. So till now we have done little more than 60 cases. I have the data of 51 cases, and the mean age of the patient is 61 years. And I would like to say that my interest is here. You can see there's a valve replacement cases. There are 3 cases. These are rheumatic heart cases with the persistent chronic atrial fibrillation, with the aneurysmal big LA, with the heart failure. So what I'm doing is, this is the protocol which I follow for the patients with the persistent chronic symptomatic atrial fibrillation. All of us in India, we have these kind of patients. We know that. And they are younger patients. So this is the protocol we follow. Like first you try medical therapy. If it fails, you try cardioversion. If it fails, if the LA is not huge, like not more than 5 or 5.5 you feel, and you feel that it's more of a LA flutter than the fibrillation, you can take them to the lab for ablation. But if you feel that LA is huge, it's more than 5.5, it's a fib and heart failure, you can go and think of doing his bundle in an AV junction ablation and follow up, but with the atrial lead, because we have done 3 cases with rheumatic in whom I have cardioverted. I never cardioverted them on the table, especially rheumatic ones. Once they remodel, we know that it takes some time for the heart to remodel, mainly the rheumatic ones. So once they come after 6-8 weeks, they feel much better. You have done AV junction ablation, you do T and then do cardioversion and then follow them. Although we don't know very long-term data, like 2.5 years data, we have most of them maintain sinus rhythm. So this is the protocol which I have prepared. So I have prepared one registry for this group of patients of rheumatic atrial fibrillation who's having chronic persistent atrial fibrillation. We are not able to manage them with the drug. We can think of doing his bundle with AV junction ablation and see the follow. So in our group of patients, initially if you can see, like mostly was CRT, 37 patients, but now we are going towards the dual chamber pacemakers. Mostly are for the CRT or the arrhythmia-induced indications. 2 were pacing-induced cardiomyopathy. 7 patients were complete heart block.
Dr.ULHAS?
17 patients were either right bundle branch or the left bundle branch block patients. So initially we were doing mainly his bundle pacing. I think I should thanks Dr. Shanmugam because he came 15-20 days back to our center. So after he came, we have started doing left bundle branch because he trained the team for left bundle branch pacing. We were not able to achieve a very good results with the left bundle branch pacing. So 11 cases after that, we have left bundle branch pacing. And now we are changing, as I said, to more of a dual chamber pacemakers. And we have now slowly we are not putting the RV backup lead for these cases. Out of these 51 cases, 4 cases we have in whom the threshold has gone up. I would like to share one more case. This is a 58-year-old male, diabetic, CAD, old antival myocardial infarction, severe LV dysfunction with EF of 25%. He had a bifascicular block on the ECG. I'll share the ECG, QRBB with LHB and the PR of 180. He had one episode of complete heart block, hospitalization, renal dysfunction, and after some time recovered, CHB recovered. And cardiac MRI showed 53% scar along with the LAD territory and the patchy scar. So this is the baseline ECG. It's a QRBB, left anterior hemi block and normal PR. So this patient, when we took, got a, I think it's a good his pacing you got. It's a VO pacing with the at 2.25 volts. And you can see right bundle has been corrected. And your LAHB has been corrected. 2 has become positive, 3 is negative, AVF is equiphasic. So it's kind of a physiological left bundle, physiological left axis. It's not pathological left axis. It's not LAHB. So I was happy with this result. But the thing is, when you do DDD, that was VO pacing. When you do DDD pacing, this was AV delay of 100 millisecond. When shifted and the device connected, you can see this still RBBB. QR pattern has gone. QRS is narrowed down, but you can see LAHB is there, and there is an RBBB. Now, why this is happening? Then I thought, okay, let's check. What I did was I switched off RV, and I just kept DDD only his pacing. The same patient with the DDD only his pacing. Again, you are having that QR pattern with the QRS getting narrowed down, and LAHB is persistent. So why this is happening? So this we all know that if your lead is above the your leaflet, tricuspid leaflet, that is the penetrating bundle branch, it's you're having a proximal hiss, and this lower if you pace, it's a distal hiss. So this may be because it's a bundle branch block, so our lead is below. Your lead is below the tricuspid valve, and maybe the AV conduction till the penetrating bundle of hiss is very robust. Because when you make it DDD, your RBBB and the LHB is still there. That means there's a robust conduction across the node and at least proximal part of the his bundle. And you're getting a fusion. That's why you're getting a narrow QRS. So what we did was, we didn't shorten because your AV delay is already 100 millisecond. You should not come below 100 millisecond. Your P should not be getting truncated. Your stim should not come on the P wave. Your stim of the V should not come on the P wave. So what was done, this patient was not on antiarrhythmic. He was not on any beta blocker because he had a history of complete heart block. The only thing done was he was started on beta blocker and sent, and he came after 2 months for the follow-up. And you can say same patients with the same setting, with the normal PR what we had kept, you are having that your LAHB has gone and right bundle branch block has gone, the same setting. Last but not the least, it's just a small data. This work already has been done. So, but we know that with the epicardial CRT lead, there is a transmural dispersion of the repolarization, mainly with the LV lead. So, because we had done few his bundle cases, we thought let's compare our CRT cases with the his bundle to see T peak to T end, which is a marker of the transmural dispersion of the repolarization, and the ratio of T peak to T end and the QT. If it is more, it's more dispersion. If it's normal or less, it's a less dispersion. So what was done in this, just divided, like it's a retrospective data we collected, 13 his bundle cases and 16 age and sex match CRT cases we took to just see what is the difference in the T peak to T end and the ratio with the QT interval. So this is the way, this is one of the CRT cases, this is the LBBB, and you can see this is how it's measured in the lateral lead, like the lead V5 usually. If you have no good T wave in the lead V5, you can measure in the lead 2. And this is how you measure T peak to T end and the corrected QT interval. And this is the same patient in whom RALV pacing is there, post CRT. And this is how you measure if it's a T wave is negative, you can measure the T peak to T end. This is one of the CRT patients, one of the his bundle patient in whom T peak to T end was measured. So you can see at the baseline, there was no difference in the his bundle or the BIV pacing. It was not statistically different. But immediately post-implant in the His bundle group, your T peak to T end and the ratio both are better with the His bundle pacing group as compared to the patients with the CRT. And this thing was maintained even with the 6 weeks post-implant. And if you compare this in the patients with the CRT versus His, the T peak to T end was better and the ratio was also better in the patients with the His bundle as compared to the patients with the CRT. So only thing is it's a very small data and it says that the conduction system pacing appears to have some beneficial effect on these repolarization patterns. Although this study was not powered to evaluate the arrhythmic risk. So only thing is we have to take this as just a small data with a pinch of salt because it's a single center and we collected the data retrospectively in the very small sample size and we didn't do like inter-observer variability for the ECG parameters. Thank you.